Welcome everyone to a new series of our webinars. Today we have the honor of having Dr. Anthony Marson here with us. Professor Marson is a consultant neurologist and epileptologist at the Walton Center, professor of neurology at the University of Liverpool, and director of research programs at Liverpool Health Partners. The team at the Walton Center runs one of the largest epilepsy services in the UK, providing comprehensive multidisciplinary experiences. His research has focused on the assessment of treatments, interventions, and services for epilepsy, and has informed policy, service, and treatment decisions worldwide. He leads the National Audit of Seizure Management in Hospitals and chairs the current NHS England Review of Epilepsy Specialist Commissioning. He has coordinated the largest randomized controlled trials in epilepsy and is chief investigator of the recently completed NIHR HTA trial of standard and new anti-epileptic drugs to SANAD 2, and is coordinating editor of the Cochrane Epilepsy Group. He is also a board member of the European Academy of Neurology, where he chairs the Congress Program Committee. The learning objectives for today are syndrome. We welcome Professor Tony Marson with us today.
Thank you very much for your kind invitation. I guess it's good evening, good morning, and good afternoon. And I'm delighted that you've been able to join me over the weekend. It's certainly been a very warm and sunny few days in the UK, which has been great to spend some time in the warm weather this summer. So I'm going to discuss the results of the SANAD 2 trial. So I'm just going to share my screen. Just take a minute or two to get that working properly. Okay, so hopefully that's all working fine, and you can see the presentation. Got the thumbs up. Excellent. Okay. So I'm going to, as I said, I'm going to discuss the results of the SANAD 2 trial, which is a trial trying to inform our treatment policy for people with newly diagnosed epilepsy. And we're in the business here of running pragmatic randomized controlled trials. And the aim of this sort of trial is to inform everyday decision-making in epilepsy. And whilst we have many randomized controlled trials in epilepsy, most of them are actually designed to inform regulatory decisions, so inform decisions about whether a drug gets licensed. And because of the way that those trials are designed and the requirements of the regulatory authorities, we're often in a position when new drugs get licensed that we don't really have the information that tells us how to use them most effectively in clinical practice. This is most problematic in refractory epilepsy, where we have predominantly placebo-controlled trials of very short duration, and whilst we have many drugs licensed on that basis, there's very little head-to-head evidence, so there's virtually no evidence to inform our choice of treatment from randomized controlled trials. There is more evidence for first-line treatments in epilepsy, but it is surprising that we have much less in the way of pragmatic trials in epilepsy than other disciplines like stroke. So in pragmatic trials, we're trying to run trials that reflect everyday clinical practice, and we need to be measuring outcomes which are highly relevant. So for a condition like epilepsy, where people may have this lifelong, we need to be measuring longer term outcomes over years. So, regulatory trials measuring seizure outcomes over a 6 to 12 month period are probably inadequate in terms of actually informing everyday decision makings in clinical practice. So the challenge is that our regulatory trials don't really inform our everyday clinical decision making, but we have relatively few trials which are actually designed to do that. It's worth just thinking about blinding in pragmatic trials in epilepsy. And we know that randomized double-blind trials are the least biased way of assessing outcomes in randomized controlled trials, but blinding can come with a few problems. So it can limit recruitment. So if we're trying to run a trial that recruits a population that represents the population we see in practice, if that population is limited by blinding the trial, then we have a kind of an external validity problem, because the population in the trial might not represent those people that we see in everyday clinical practice. For example, women of childbearing age might be excluded. And of course, blinding departs from everyday practice, particularly if we use double dummy techniques, and blinding may need to be broken if the treatment fails, so that we can find out what the patient's been on, so that we can then decide what to prescribe next. And as soon as we start breaking the blinds, we're starting to interfere with the integrity of blinding. And blinding is also an expensive thing to do. So from the point of view of the SANAD trial, we had funding for about £2 million from the NHS Health Technology Assessment Programme in the UK to run the trial, but blinding would have nearly doubled the cost, and that would have made it probably unaffordable for the public funder. So here we've got really a trade-off between internal validity and external validity. So if you're wanting to get information that's going to inform regulatory decisions, you want high internal validity, because you want high assurance that the findings are accurate, even if it's in a very restricted population. But in terms of informing everyday clinical practice, we also want high external validity, and there's a risk that blinding in long-term epilepsy trials will reduce external validity. So we've got a trade-off really, and from the point of view of informing treatment policy, the external validity gains from unblinding a trial may well trump the internal validity losses, and that's certainly a view that we've taken, and a view that the funder agreed with when funding the SANAD 2 trial. So the SANAD 2 trial was effectively two trials, and the first is a trial in patients with newly diagnosed focal epilepsy. So I'm just going to talk you through some issues around the design and then the results of that trial. So this trial recruited patients with newly diagnosed focal epilepsy. There were people aged over the age of 5 years with newly diagnosed focal epilepsy. And lamotrigine was chosen as a first-line standard treatment, because that's become the first-line standard treatment for people with newly diagnosed focal epilepsy in the UK. And lamotrigine was the treatment that was most effective in terms of seizure control and tolerability in the first SANAD trial that we ran. So patients were recruited and randomized to sort of treatment with either lamotrigine, levetiracetam, or zonisamide, and we've recruited 990 patients. Because it's a pragmatic trial, we actually have very few inclusion and exclusion criteria. So we've recruited people aged over 5 because we didn't want to include children with pediatric encephalopathies. We wanted to recruit people with what we'd all recognise as the common focal epilepsies. People had to have 2 or more seizures to be recruited, because although the definition of epilepsy has changed and can include people with first seizures and a high risk of recurrence. By and large, we will only really start treatment once people have had 2 or more seizures. We excluded people with provoked seizures. We obviously didn't want people with alcohol withdrawal seizures, and we wanted this to be a cohort of people that were treatment naive. We also tried to exclude people with progressive neurological diseases, but there are a small number of people with brain tumours that have crept in, because we might make a decision to start treatment before we've done a scan, and so there are after which we may have found a tumour. But there's only a small number of people with tumour in the study. The outcomes were these listed on the slide. So the primary outcome was time to achieve a 12-month remission from seizures, and the trial was designed to detect non-inferiority, and I'll talk a bit more about the concept of that over the next couple of minutes, just to make sure we all understand what non-inferiority is about. Our secondary outcomes were time to a treatment failure, adverse events, quality of life, and health economic outcomes. So I just want to say a little bit about non-inferiority and how we designed it. And the first thing to say is that if you power a trial to identify non-inferiority, it will inevitably have the power to detect a difference, because you tend to need more patients to detect non-inferiority than you do to detect a difference between treatments. So the picture here is a hypothetical curve for time to a 12-month remission. That the comparison here is actually going to be a discussion around valproate and levetiracetam, but the principles are the same. So we've got an estimate. We know how patients on our standard treatment are likely to behave. So we've got the proportion achieving a 12-month remission over time. And what we need to think about is, okay, if we're going to try and identify non-inferiority, what size of difference do we want to be able to exclude between 2 treatments? And whilst this is a statistical concept, it's not a statistical answer to that question. It's very much a judgment as to where that smallest important clinical difference lies, and it involves asking patients and the public and clinicians what they think. This hasn't been completely or adequately studied in epilepsy at the moment, but it's probably around a 10% difference in remission rates. So we, based on what literature was available and from asking around, we decided to power SANAD 2 with a non-inferiority limit of 10%. So we've decided what that effectively means is we want to power the study to exclude 10% difference, and how we've conceptualized this, we want to exclude the possibility that valproate is 10% better than levetiracetam, or lamotrigine is 10% better than the focal epilepsy alternatives. But the analysis is a time to event analysis. So the statistic that is generated is a hazard ratio. So we need to turn this 10% into a hazard ratio, and in this example it comes out at a hazard ratio of 1.3 and a bit. So what we need to do now is generate confidence intervals that don't cross that line. So here's an example of finding of non-inferiority. So we've got an estimate here which is pretty close to 1, and we've got a confidence interval, upper end of the confidence interval, which doesn't cross this 1.329 barrier. So if we found this, we would have a finding of non-inferiority. If we find this, we would actually be finding that levetiracetam is superior to valproate, and if we found this, we would find that levetiracetam is inferior. But we've designed the trial to have enough patients in it to potentially find this non-inferiority if it exists. So we recruited 990 patients, and they were randomized to lamotrigine, levetiracetam, or zonisamide, as I've said. Almost all of the patients were included in the intention to treat analysis, and a small number were excluded in the per protocol analysis. And I'll talk more detail about the per protocol analysis when I present the results for that. And what I should say is that we followed everybody up for a minimum of 2 years, and the first patients randomized in the trial were eligible to be followed up for 6 or 7 years. So we've got a lot of follow-up data available to us. So the slide here just summarised the age distribution of the patients that were recruited into the focal epilepsy elements of the trial. And what you can see is that there's a fairly broad distribution across the age groups, although the elderly aren't very well represented in the study, and neither are those aged less than 10. But covering the age distribution. Oops. There were slightly more males than females, and in terms of the classification of their focal epilepsy, about 40% were classified as having a temporal lobe epilepsy, and about half of them were diagnosed with focal epilepsy, but the clinician couldn't confidently say at the point of time of diagnosis whether it was definitely temporal, frontal, etc. The median number of seizures people had before being recruited into the study was 6, and the median number of days since their last seizure and being recruited into the trial was 13 days. So people were recruited within a few weeks of being referred to their local epilepsy service. For those with more of an interest in the EEG, the slides here summarises the basic data that we collected about EEGs. About nearly a third of patients didn't have an EEG, and that's pretty common in UK practice. And if we've made a confident clinical diagnosis of a focal epilepsy, we won't always get an EEG, although we encouraged the collaborators to get an EEG if they could for patients that were recruited into the study. Just over a third of the patients had a normal EEG, and the most common abnormality was a focal abnormality with spiking. I think this is fairly typical of what you would see in a broad population of people with a newly diagnosed focal epilepsy. In terms of their MRI imaging, again, there's about a quarter of patients that didn't have an MRI scan at the start of the study, although some of these will have had an MRI scan of their brain at another time. Nearly half of them had a normal MRI scan, and then there are a range of abnormalities that were detected. And again, highlighting that we're recruiting a broad range of people with focal, newly diagnosed focal epilepsy with a range of lesions when identified. Okay, so the results on this slide are for achieving a 12-month remission, so time to achieve a 12-month remission. So hopefully these sorts of plots are familiar to you. So along the y-axis here, we've got the proportion of people achieving a 12-month remission, and along the x-axis here, we've got time in days. And just to orientate you in terms of colours, we've got a blue line for lamotrigine, a green line for zonisamide, and a red line for levetiracetam. And what you can see is in this intention to treat analysis that the curves are fairly close together. And when we look at the overall results, we find when we compare lamotrigine and levetiracetam, the estimate of the hazard ratio 1.19 is in favour of lamotrigine, but the confidence interval crosses this 1.329 barrier. So our estimate suggests that lamotrigine is better. The difference isn't statistically significant, but we also can't conclude that levetiracetam is non-inferior. Okay, so it's in that kind of no man's land between no difference, but we can't say that it's non-inferior based on these results. The results for zonisamide are different, and the estimate for the hazard ratio is 1.03, so pretty close to 1. And this time our confidence interval doesn't cross this 1.329 barrier, suggesting that zonisamide may be non-inferior for this outcome. But what we need to remember is this is an intention to treat analysis. So when we do an intention to treat analysis, what we're really doing here is comparing the policy. So what happens if we start lamotrigine first versus levetiracetam first versus zonisamide? And of course, what we're doing in clinical practice is that we're making adjustments to dose and treatment during follow-up to try and do our best to make sure that people's seizures are controlled. So it's inevitable that there are patients that aren't going to be on the treatment that they were randomized during follow-up. And so when we do a per protocol analysis, what this is doing is taking treatment failure into account. So this is estimating, well, what proportion of people achieve remission on the treatment that they were randomized to. And here we see a different picture. We see our blue line for lamotrigine is ahead, about 70% of patients ultimately achieving a remission on lamotrigine, whereas it's nearer 50% on both levetiracetam and zonisamide. And when we compare them this time, we see that lamotrigine is superior to levetiracetam and lamotrigine is superior to zonisamide. When we look at first time to a first seizure after randomization, we get plots like this, where the curves are almost superimposed. I think what this tells us is that we probably recommended titration schedules and initial maintenance doses, which were broadly equivalent, and it provides some assurance that the titration schedule for lamotrigine didn't result in people having earlier first seizures. And I think that certainly following the first SANAD trial, that there was some concern that lamotrigine might be exposing people to earlier first seizures if it's got a slower titration to try and reduce the risk of a rash. But we certainly weren't seeing it in the analysis of the SANAD-2 data. Okay, so that's the initial seizure outcomes. If we now look at time to a treatment failure, we get plots like this. And treatment fails either because it's not controlling seizures, or it's causing adverse effects, or a combination of both. So what we've got here is the proportion of people staying on the treatment that they were randomized to. Okay. And I think it's pretty clear that we've got people staying on lamotrigine longer than they were staying on levetiracetam, longer than they were staying on zonisamide. And I guess we can kind of predict that from looking at the difference between the intention to treat analysis and the per protocol analysis for the time to a 12-month remission. And these differences are statistically significant. So lamotrigine is statistically significantly superior to both levetiracetam and zonisamide for this outcome. And we can also split this for the two main reasons for treatment failure. So on the left-hand side of the slide here, we've got treatment failure because of adverse reactions. And on the right-hand side, we've got a failure for inadequate seizure control. We can see that there appears to be more of a difference in terms of failure for adverse reactions, with zonisamide having the highest failure rate due to adverse reactions, followed by levetiracetam, followed by lamotrigine. And the difference between lamotrigine and the other two treatments, again, is significant here. Whereas failure for inadequate seizure control is pretty similar, and we don't actually find any statistically significant differences. Okay, so I'm going to jump now to the adverse reactions data, and quite a few numbers on this slide. So the first three columns here are the number of events, and the next three are the number of patients, because some patients had more than one event. And the main thing to highlight is the higher number of psychiatric events on zonisamide and levetiracetam. Feelings of agitation, anxiety, depression were more common on levetiracetam and zonisamide than they were on lamotrigine. Of course, we need to be careful when we're interpreting these data because this is an unblinded trial, so there is a risk of greater attribution based on expectation. But the differences are quite marked, and it's unlikely that this is just a bias, although there is potential bias in the estimates. In terms of severe adverse reactions, there were relatively few of those, and the severe adverse reactions are ones that typically will result in a hospital admission or some other severe event, and there were certainly more psychiatric events labelled for patients taking levetiracetam. Okay, there were 37 deaths in the study, 15 on lamotrigine, 12 on levetiracetam, 10 on zonisamide, and this is probably kind of death rate that you would expect in the population that we recruited, given their age spectrum. The number of seizure-related deaths were similar amongst the groups, although relatively small. 3 in the lamotrigine group, 2 in the levetiracetam group, and 2 in the zonisamide group. I highlighted that there were none due to arrhythmia with lamotrigine. Just highlighting that, given the FDA statements and comments probably about a year ago now. But we certainly weren't identifying higher rates of cardiac rhythm related events in our cohort with newly diagnosed epilepsy. In addition to assessing clinical effectiveness, we also needed to assess cost effectiveness, because ultimately health services need to make a decision about whether they want to recommend treatments based on the benefit that the health service or society will get based on what they're paying for the treatments. So we undertook an economic analysis in SANAD 2, and we were trying to estimate the cost per quality adjusted life years. So there's a lot of numbers on this slide again, but I'm only going to focus really on the top part of the slide, and the bottom line is that the levetiracetam and zonisamide are more expensive than lamotrigine. They deliver less in the way of quality of life benefit, and therefore they generate less in the way of quality adjusted life years. Economists call this as being dominated because lamotrigine is cheaper and delivers more quality of life than the other two treatments. So lamotrigine dominates levetiracetam and zonisamide in this cost effectiveness analysis. And another way to look at this is to generate cost effectiveness acceptability curves. So in the UK, we have our National Institute for Health and Clinical Excellence, and they will generally recommend treatments for the National Health Service if they come in at a cost effective at a £20,000 per quality adjusted life year. And they might be interested in recommending treatments if they're cost effective at £30,000 per quality adjusted life year. So what this graph is trying to show is estimates that the different treatments are cost effective at different thresholds. But because lamotrigine dominates the other two treatments, we've effectively got flat lines. So we've got lamotrigine up here. So whatever you're going to pay for lamotrigine in this analysis, it always comes out as the most cost effective option. Whereas even if zonisamide and levetiracetam were cheap, they still would not be cost-effective options for the NHS because they are overall less effective and don't generate benefit in terms of quality of life compared to lamotrigine. Okay, so just some broad conclusions for the focal epilepsy data. Lamotrigine appears to remain clinically and cost-effective first-line treatment, whilst the zonisamide came out as non-inferior in our intention to treat analysis. The rest of the data tell us that it's not really a good first-line treatment for focal epilepsy, and neither is levetiracetam, largely because of their higher adverse event rate, and also they don't come out as cost-effective in the cost-effectiveness analyses. So it's pretty clear evidence to make us think about whether we should be using levetiracetam and zonisamide as first-line treatments. These data suggest that we should not. And obviously, we're all aware that levetiracetam has become very commonly used as a first-line treatment in focal epilepsy. It's very common for people to attend the emergency department and walk out with a prescription for levetiracetam, but the data here suggests that that is not in patients' best interest, and perhaps treatment policies should change. Okay, so I'm going to talk you through the data for the second trial, which was a trial comparing valproate and levetiracetam in people with generalized and unclassified epilepsy. So the design, of course, mirrored the trial in focal epilepsy, but this time valproate is the standard first-line treatment, but we've randomized people to treatment with valproate or levetiracetam. To meet our, or rather to power it for non-inferiority, we needed 520 patients, so 260 patients were recruited in each arm. The outcomes were the same, so and the analysis. So I'm going to just jump straight now to the headline results. I'm just going to check on the time, see how we're doing. Okay, we're fine. So slide here summarizes the main patient characteristics, and because it's largely a trial of patients with idiopathic generalized epilepsy, we shouldn't be surprised that it's a trial recruiting mainly children and younger adults. There were some older patients in it, but these were people with unclassified epilepsy. There was a preponderance of males, as you would expect, and in fact, very few women of childbearing potential were recruited. So the females were primarily younger women, children, or they were more mature women with unclassified epilepsy. Nearly 10% had a learning disability. Nearly 20% had a first-degree relative with epilepsy, as we would expect, really, in a cohort of people with idiopathic generalized epilepsy. So, 3/4 of patients had an idiopathic generalized epilepsy, and about 25% were patients with unclassified epilepsy. And I think it is interesting to observe colleagues' uncertainty and how they handle uncertainty. Some unwilling to call it focal epilepsy unless they've had a really confident story of a focal onset seizures, whereas I think I'm someone that, you've seen a 60-year-old that's had 2 nocturnal tonic-clonic seizures. They've got focal epilepsy until proven otherwise. So the unclassified group is quite a mixed group. In terms of the EEG results, about a quarter had a normal EEG. Largely those with an unclassified epilepsy. Half had generalized slow and spiking, and then the range of other abnormalities. So I think reflecting practice in terms of recruiting patients with a likely generalized epilepsy. In terms of the syndromes, it's about 22% were classified as having a childhood or a juvenile absence epilepsy, about 13% JME, nearly 6% with generalized tonic-clonic seizures on waking. But the biggest group, about 45%, were patients with idiopathic generalized epilepsy not specified, and that's pretty typical. And we had and it reflects what we found in the SANAD 1 study. whilst these are primarily people that have had 2 tonic-clonic seizures, they've got spike wave on their EEG, but the clinician doesn't feel confident that they can attribute a specific classification at the time that they start treatment. So many of these will have had a more definite syndrome given during the course of follow-up. But if we're running a randomized controlled trial, we need to stick with the data that we collected at baseline. Okay, so here we have the results for time to achieve 12-month remission. So this time we've got a red line representing valproate and a blue line representing levetiracetam. And immediately there's about nearly a 10% difference in the remission rate. So nearly 10% more patients achieving an immediate remission on valproate than levetiracetam. And over the next couple of years, the lines catch up with each other. So early on, if we look at just early on, we see that there are important differences between the 2 treatments, but those diminish over time. And again, of course, what we've got here is an intention to treat analysis comparing this policy of starting one treatment or another. And what's happening during follow-up is that we are doing our best, making changes to dose and then treatment to try and get people's epilepsy under control. So it's, you would expect, if we were doing our job properly, that whatever patients started with, we would get similar proportions into remission over the course of follow-up. If we just look at the comparison of the entirety of the data, we get a hazard ratio of 1.19 in favor of valproate. It doesn't quite reach statistical significance, but our upper confidence interval crosses again this non-inferiority margin. So we can't say that levetiracetam is non-inferior overall. And if we just focus on what happens at the start of treatment, we see that levetiracetam is inferior in that short time period. So again, if we now look at a per protocol analysis where we're taking treatment failure into account and we're looking at what is the proportion of people that actually achieve a remission on the treatment they were randomized to, we see that ultimately about 60% of the patients randomized to valproate achieve remission on that drug, whereas it's nearer 40% of patients that are randomized to levetiracetam. Quite a big difference, and not surprisingly, that is statistically significant. We decided that we would do some post hoc subgroup analyses. So we split the cohort into 3 main groups: those with an absence epilepsy, everybody else with an idiopathic generalized epilepsy. So this is people with generalized tonic-clonic seizures with or without other generalized seizure types, and then our unclassified group. And what you can see broadly is there's probably not a lot going on between the treatment policies in terms of absence seizures, but there appears to be a bigger difference for the other generalized group, and there's not a lot going on for unclassified. And that might seem a bit counterintuitive at first, knowing our view that levetiracetam probably isn't a great treatment for absence epilepsies. But what we need to think about is, well, absence seizures are quite frequent events. So we're going to find out that levetiracetam is failing quite quickly and adjust treatment. So I think what's going on here is that we've got an epilepsy syndrome where people are having frequent seizures, and we're making fairly rapid changes to treatments, which is why the policies there isn't a lot of difference between the policies in an intention to treat analysis. Whereas for generalized tonic-clonic seizures, they have a relatively low rate, so it's going to take us much longer to work out that treatment is failing, rate increasing the dose, and ultimately changing to another treatment. So it's people with a lower rate of seizures, people with generalized tonic-clonic seizures, that are most disadvantaged from this policy of starting levetiracetam as opposed to valproate. Okay, so the data here are for our time to treatment failure outcome, and of course we see that patients are staying on valproate longer than they're staying on levetiracetam, and the effect is quite large and statistically significant. And again, we can look at the treatment failure for our two main reasons for treatment failure, so adverse events or inadequate seizure control. And the results are different this time to what you saw in the focal epilepsy, if you can remember the data. If you remember, for the focal epilepsy, the difference was in failure due to adverse events, whereas here we see that the curves are largely superimposed. So failure for adverse events is pretty similar for valproate as it is for levetiracetam. And I think our prejudice was that levetiracetam was a pretty safe treatment, doesn't cause much of the way of side effects. I think it's probably just that we weren't looking out for the side effects that it caused when we did our initial trials. But certainly in terms of treatment failure, levetiracetam and valproate appear very similar for adverse events, whereas treatment failure for inadequate seizure control, levetiracetam much more likely to fail than valproate. And again, we can look at the impact for our three subgroups. So this is looking at our three subgroups. Again, this time we've got a forest plot, but we've got our three groups: absence epilepsies, other generalized epilepsies, and unclassified. And here we see that, absence epilepsy, valproate significantly better; other generalized epilepsy, valproate significantly better. But interestingly, for our unclassified group, the estimate suggests that levetiracetam might be better, although the confidence interval crosses 1, and that's interesting because most of these patients probably had focal epilepsy. So is this perhaps telling us that levetiracetam may be a better treatment than valproate of focal epilepsy? It's possible, but obviously that's not the question that the study was primarily designed to answer. If we look at treatment failure due to adverse events, we've got differing estimates, but our confidence intervals are pretty wide and cross 1, so no significant results there. And again, if we look at our failure for inadequate seizure control, again, we see this effect for absence and other generalized epilepsy, with valproate being better, and an estimate suggesting that levetiracetam may be better for our unclassified epilepsy group. And it's a similar story in the generalized epilepsy group as the focal epilepsy group, when we look at adverse reactions, and we see this greater number of psychiatric events associated with levetiracetam compared to valproate. Of course, we've recruited some women of childbearing potential, and we had one pregnancy in a woman randomized to the valproate group, although she came off valproate prior to conceiving. And then there were 9 pregnancies in women randomized to levetiracetam, a range of outcomes, including 3 miscarriages, 1 low birth weight, 1 with major malformations, and the remainder were normal healthy babies. None of these, again, were obviously these are all randomized to levetiracetam. I think these data do, I think, well, they certainly give me pause for thought, because oops, what have I done? I've touched the mouse. So they give me pause for thought. What message are women taking away from that initial counselling? Has the fact that these women started on valproate had a big impact on their decisions about future fertility, whereas the women starting levetiracetam got a different message? Because whilst the numbers are small, clearly there's nine pregnancies in one treatment group versus 1 in another, and we know that the number of women with childbearing potential was smaller there were certainly many more males in that age group as we were adhering to our pregnancy prevention program that came through in the UK during the course of the trial. So I haven't put the table in for the cost effectiveness data here. I've just put in the cost effectiveness acceptability curve, which isn't quite as stark as the previous example, but it's a pretty similar story. So if we look at the probability that either levetiracetam in red or valproate is cost effective at different payment thresholds, here's our 20,000 pounds per quality adjusted life year and our 30,000 pounds for quality adjusted life year. Here there's a high probability that valproate is cost effective and a pretty low probability that levetiracetam is cost effective. So the overall conclusions here are that levetiracetam is neither clinically nor a cost-effective treatment for newly diagnosed generalized epilepsy. Levetiracetam didn't meet our definition of non-inferiority. It had a significantly higher failure rate, and our per protocol analysis showed that clearly that almost 20% fewer patients were achieving a remission on their randomized drug. It wasn't associated with quality of life gains, and it didn't come out as cost effective in the cost effectiveness analysis. Of course, that makes it remain straightforward for managing men with an idiopathic generalized epilepsy, but it means that we've still got challenges for managing women with an idiopathic generalized epilepsy. I think regulations in most countries are warning against starting valproate as a first line treatment. So most women will be started and will probably choose to start an alternative, either levetiracetam or lamotrigine, but we've got good evidence now that both of those treatments are inferior in terms of treatment control, in terms of seizure control. And I think we need to think hard about what should be the policy once their first treatments fail. How many treatments do they need to fail before they can start valproate? And of course, that's a decision that the woman needs to be involved in as well. I think the final comment that I would make is that I think the lessons from this, on top of the SANAD 1 trial, is that we should no longer lump unclassified epilepsy in with generalized epilepsy. We still do have the challenge of unclassified epilepsy is a fairly common thing in epilepsy. We see patients where we decide we need to start treatment, but we can't confidently classify their epilepsy, and we need to generate evidence to inform decisions, but we need to find a different way other than recruiting a cohort of people with generalized or unclassified epilepsy, where traditionally we've thought of valproate as being the standard first line treatment. Okay, thanks for your attention. I'll stop now. I've no idea whether any questions have come in on the chat, but I guess we're about to find out. I will stop sharing.
Thank you so much, Professor Marson, for such a wonderful and very enlightening explanation of both trials, SANAD 1, SANAD 2. And also for these two arms that you explained us today. We do have some questions. One of the questions is regarding lamotrigine in the focal epilepsies. If the time to like tapering and to increase the medication would affect a little bit quality of life and seizure control in these patients, or was it negligible?
Yeah, so our time to first seizure analysis tells us that wasn't really an issue. So I didn't, of course, tell you the titration rates that we recommended. So our recommendation was that 25 milligrams a day for 2 weeks, then 50 milligrams a day for 2 weeks, 50 milligrams twice a day for 2 weeks, then 50 in the morning and 100 at night. So over a 6 to 8 week period, people were titrated up, and people were titrated up a little more quickly with levetiracetam and zonisamide. But the time to first seizure analysis actually showed that there weren't more people having first seizures on lamotrigine. And in terms of quality of life, what the quality of life analysis shows you is that the other treatments were causing more side effects. So lamotrigine was causing sort of less in the way of quality of life reduction because it was causing fewer side effects.
Fewer side effects, correct. We have also a question regarding the absence epilepsy group. These patients tend to do. There were not a lot of difference with levetiracetam, but then you showed the forest plots which represent a big difference. What can you say about this group of patients?
Yeah, so what I showed you the per protocol analysis for time to 12-month remission. That showed a very clear difference between valproate and levetiracetam, and you see the same sort of thing when you look at the absence epilepsies. What I showed you in the slide was the intention to treat analysis. So what that shows you is that even if you start levetiracetam, if it's failing, you find that out quickly and you switch them to valproate or ethosuximide to control the epilepsy, and that's what was happening. So in terms of a policy, actually patients with absence epilepsy weren't disadvantaged too much because they quickly got onto an effective treatment. The people that are most disadvantaged from starting levetiracetam are people with tonic-clonic seizures, because those seizures don't happen as frequently, so it takes you much longer to find out that you've chosen the wrong treatment for them. And of course, they're the people that are most at risk of injury and potentially sudden unexplained death in epilepsy, although of course that's rare, and that didn't certainly come out as there wasn't a higher mortality rate in the levetiracetam group. But the main impact was on reduced quality of life and more side effects.
We have another question. What happens with the patients that do not respond to first line? What would be the focus that we should have in these patients that are probably going to be patients with drug-resistant epilepsy? Yeah,
so of course that's not a question that we tried to answer in the SANAD study, and the evidence base to inform that is relatively weak. We still really don't know whether the best policy is to try an alternative monotherapy or to go straight for dual therapy. I can tell you what I do in clinical practice, that if patient is failing because of inadequate seizure control, I don't tend to try an alternative monotherapy. I tend to go straight for dual therapy. If they're failing because of adverse events, then it makes sense to switch to an alternative. Although the challenge, of course, is that lamotrigine often, lamotrigine causes fewer side effects than carbamazepine, so swapping someone from lamotrigine to carbamazepine because of adverse events doesn't always make a lot of sense. So it can be tricky, and of course we then maybe thinking about levetiracetam or other alternatives to lamotrigine. But the evidence base is relatively poor, and it becomes increasingly trial and error as time goes on.
Okay. Why didn't you include lamotrigine in the when you were studying generalized epilepsies? Why wasn't it an option of randomization?
Yeah, so I guess I should have just reminded you of the results of SANAD 1 before I launched into SANAD 2, but I was aware that obviously I wanted to leave some time for questions. So just to remind you, SANAD 1 compared valproate, lamotrigine, and topiramate for newly diagnosed generalized unclassified epilepsy, and that showed that lamotrigine was inferior. You could have argued, well, okay, you could have got even more evidence about lamotrigine by including it in SANAD 2. We probably don't need more evidence about that, and that would have meant that we would have needed to recruit another 300 patients, and that would have taken another 3 or 4 years to answer the question, and it didn't make sense to include lamotrigine. The same can be said for the focal epilepsy arm. We considered whether we should either include lacosamide or lamotrigine in the focal epilepsy arm, but it was very clear that our funder didn't want a bigger trial. They wanted results as soon as they can. And it took us 10 years. It's taken us 10 years from getting the funding to recruiting the patients, following them up and analyzing the data. So, if it had taken us the 3 or 4 years, I think people would have lost patience with us.
I was surprised to see the doses of the different medications. I practice in a place that uses higher doses. So you think the doses that you use, the maximum doses that you used, were enough to control these patients?
Yeah, so what you can see is that most people at the end of the day ended up with their seizures under control, and there's always that trade-off between efficacy and side effects. People need to make judgment for themselves, but my view is that reasonable doses were tried. I think I have observed that in the US, higher doses tend to be used than in Europe. I don't know why that is. And, if you look back at the topiramate studies, ghastly doses of 1,000 milligrams of topiramate were used in some of the trials, for example. I mean, I guess there is a transatlantic difference in management approach, but traditionally we've started low. We have a start low and go slow policy.
Perfect. Could you tell us a little bit about your journey in getting funding? How was it? Because, for example, for new investigators like myself and others that are watching, it's kind of overwhelming when it comes to how to get funding and how this process starts. Could you give us a little bit of insight on your own?
Yeah, so I guess the first thing I would say is that if you've got a good idea, you've got to be tenacious and determined. So most of my big projects have been funded third time lucky, and SANAD 2 was funded third time lucky. Of course, we'd got the track record of running SANAD 1 and other trials, and we have a funder in the UK, our National Institute for Health Research Health Technology Assessment Program. Obviously, you have similar programs in the States, but they want to fund trials that are going to inform everyday decision making in the National Health Service, and hope that they will also be relevant to the rest of the world. What is increasingly important is to be working with patients and the public to ensure that the questions that you're answering are relevant to what the patients and the public want. It's also really important to be working with a trials unit. So you need to be working with a unit that has got a track record and understands how to deliver clinical trials. And you need to work really hard on establishing and working with a network. And a network of collaborators. So SANAD 2 was run through about 100 centres in the UK, which is quite a major undertaking. One of the lessons I've learned over the years is that people are really interested in collaborating if you're trying to answer a question which might influence what they do on a day-to-day basis. I've had one project that failed and had its funding withdrawn because we weren't recruiting, and the lesson I learned there was, people aren't that interested in recruiting to a study if the benefit to them in terms of knowledge is just too far away. So you need a good group of collaborators. You need to be working with the public. You need to know your funder, and you need to be tenacious because it's still a lottery. Boards make decisions. It's a bit like submitting papers. Really good papers get rejected by good journals for reasons that are really frustrating. You just got to keep going. If it's a good idea, it'll get funded.
Excellent. Well, these are all the questions for now. We again thank Professor Anthony Marson for such a wonderful talk today, and we encourage you to keep posted because we are going to have other webinars coming up. We have next week Professor Natalie Jete, who will be talking about neuroepidemiology. So keep the spirit, and we'll see you next time. Bye-bye.
Bye.